start with the topic, fertility preservation strategies in male and female. So globally, each year there is a rise in the number of cancer patients, and according to ICMR and NCDIR, National Cancer Registry Program, it is estimated that the annual number of cancer cases will rise from 13.9 lakhs in 2020 to 15.7 lakhs by 2025. So this is almost 12% increase in the cancer cases in the country by 2025 based on the current trend, and more than 1,40,000 cancer patients are diagnosed to be in the range of reproductive age, and the childhood cancers are also increasing day by day. But at the same time, with the early detection and the advanced diagnostic techniques and the advanced modalities, treatment modalities, efficacies and safeties, the overall survival rate is also improving. So nowadays the focus of cancer treatment is shifted from survival only to the survival and the quality of life. So it's not just the cancer treatment, but cancer itself can have a deleterious effect on the reproductive health by any one of the means. It could be either disruption of hypothalamic pituitary gonadal axis, or via direct immunological or cytotoxic injuries, or systemic processes such as a fever or malnutrition, or it can be a psychological issues like anxiety or depression. These cancer can impair spermatogenesis and can have a negative impact on the semen parameter. And in female, it can result in amenorrhea, anovulation, early menopause, or it can have a negative impact on the fertilization and implantation. So the cancer treatment on reproductive health. So the cancer treatments like chemo, radio has a deleterious a toxic effect on the fertility. Not only that, it impacts on the growth, puberty, as well as the sexual dysfunction. So the factor that determines the likelihood of reproductive damage is either it is disease related or it is patient related. The disease related are cancer type and stage, pelvic surgery, chemotherapy type and dosage, abdominal, pelvic and hypothalamic radiation and dosage. In case of patient related, it can be the ages, genetic factors and pretreatment fertility. So the cancer treatments on male reproductive health, chemotherapy, radio and surgeries, they usually impair the spermatogenesis, and it can result in injuries to the germinal epithelium. It can damage the nerves or the blood vessels, leading to erectile or ejaculatory dysfunction. It can suppress the HPG axis, or it can produce direct DNA damage, so resulting in transient oligospermia, or transient azoospermia, or irreversible azoospermia. But if there is a transient oligospermia, the recovery takes up to almost 18 months. If it's a transient azoospermia, the recovery takes up to 30 months. And if it's going to be an irreversible azoospermia, it can take up to 3 to 5 years, or it can be a permanent one. Cancer treatment on female reproductive health. So all these anti-cancer treatments can cause depletion or loss of primordial or growing follicles, loss of hormone production. It can lead to early menopause, or it can decrease the uterine volume and vascularity, fibrosis of the myometrium, or it can have a hormonal dependent endometrial insufficiency or atrophy. These all can result in poor fertilization and implantation. It can result in mid-trimester pregnancy loss, or it can be a preterm labor, IUGR. So the recommendation by the European Society of Medical Oncology, Clinical Practice Guidelines 2020, so it has stated that all patients of the reproductive age should receive complete oncofertility counseling, and the oncofertility counseling should be individualized based on the patient, couple and the disease treatment related factors. Mental health professionals and genetic counselors should be available at the time of counseling. All patients with the potential fertility interest should be diverted to the fertility unit, and every patient should be considered as being at a potential risk of developing treatment-related gonadotoxicity. So, estimating the risk of infertility, the clinician should consider both pre-treatment factors and the markers. So the pre-treatment factors are reproductive and obstetric history, history of sexually transmitted diseases or complications, history of surgery or trauma to the reproductive organs, family history of infertility or underlying medical conditions that could result in infertility. So the gonadal markers for monitoring fertility function in patients undergoing cancer treatments, they are usually the hormonal evaluation, it's FSH, LH, estrogen, testosterone in case of male, and AMH and basal level in Heben B, and in male the additional examination would be the semen analysis. So during the estimation of fertility, risk of fertility, there are online tools are available. An individualized risk assessment based on the age, cancer diagnosis, treatment, and fertility, future fertility goals. Usually the gonadotoxic risk are stratified into 4 categories. Either it can be no risk, low risk, intermediate, or high risk. Fertility preservation strategies. So these strategies may not be suitable for all. The success rate of each fertility preservation option depends upon the patient's age, health condition, variation in dosage of anti-cancer treatment. The treating center should be well equipped, highly specialized team of oncologists, gynecologists, reproductive biologists, transplantation surgeon, and research scientists forms a specialized team. Fertility preservation strategies in female. So the established protocols are gonadal shielding, ovarian transposition in case of prepubertal girls, and in case of postpubertal we have oocyte cryopreservation, embryo cryopreservation, gonadal shielding, and ovarian transposition. We have investigational procedures: ovarian tissue cryopreservation, in vitro maturation, and autotransplantation, whereas in postpubertal we have GnRH analog, again ovarian tissue cryopreservation, IVM, and autotransplantation. So gonadal shielding in case of radiation therapy, to reduce the dose of radiation delivered to the reproductive organs, gonadal shielding is used, but the limitation are it's possible with a selected radiation field and anatomy. Expertise are required to ensure that the shielding does not increase the dose delivered to the reproductive organ, and the gonadal shielding cannot be used in combination therapies like when it's given along with the chemotherapy. Ovarian transposition. Ovaries are mobilized from the field of radiation to protect the ovarian function. So in case of pelvic radiation, the pelvic brim, it's shifted to the pelvic brim either in the paracolic gutter or anterior abdominal wall. In case of craniospinal irradiation, it's fixed laterally away from the spine. And in case of laparoscopic, it's another option is laparoscopic modification, where the ovaries are temporarily affixed to the anterior abdominal wall with the non-absorbable sutures. And once the radiation treatment is done, the sutures are cut so that the ovaries are repositioned back. But during this procedure, the fallopian tubes might get damaged. So in that case, IVF is the only option. So pregnancies are achieved even without surgical repositioning. Oocyte cryopreservation, which is again nowadays the established treatment option, which can be given in unmarried or the patient who do not have a partner, or in those patients who have ethical or religious objections to embryo storage. And it's highly recommended in patients who have a fair chance of a good ovarian reserve, and the medical condition allows controlled ovarian stimulation and egg retrieval. So usually in oocyte cryopreservation, the patients undergo ovarian stimulation. I think I'm not going in detail of this ovarian stimulation, as the next topic will be covered by Dr. Snehal. So ovarian stimulation, it's given to recruit multiple follicles, and followed by that is the oocyte retrieval. And once the oocytes are retrieved, they are denuded and they are frozen. They are first subjected to vitrification solution of higher concentration, and they are vitrified. So the vitrification or the oocyte cryopreservation can be done either in a GV stage or in the M1 stage, but the M2 stage. In case of GV stage, there is no the advantages, there is no delicate spindle apparatus, and the chromosomes are protected within the nuclear membrane. But only disadvantages, it's not appropriate approach in terms of survival and maturation. Whereas in M2 stage, we have to be little cautious because the oocytes are extremely sensitive to temperature changes, and there is a depolymerization of the meiotic spindle. The zona hardening can happen, and there is a premature release of cortical granules. Next strategy is the embryo cryopreservation, which is a very established technique and it provides a good success rate. Patients who have a partner and have time to delay the therapy can undergo embryo cryopreservation. Again, here we give ovarian stimulations to recruit multiple follicles, followed by oocyte retrieval, and we either do IVF or ICSI procedure. So once the embryos, we culture them in the media, day 1, day 2, anywhere between 2 to 4 cell stage, day 3, it's anywhere between 6 to 8 cell stage, day 4 and day 5, usually we do the embryo cryopreservation on either day 3 or day 5. So the investigational fertility preservation strategies in females, they are GnRH analog, which usually used in prepubertal girls, and these are given to suppress the gonadotrophin levels and decrease the utero-ovarian perforation to protect the ovaries from chemotherapy. But whereas the guideline ESMO and ASCO guidelines in 2020 has showed that there is no evidence or insufficient evidence with the use of GnRH analog. But once this study is done, after this guidelines, there is another publication by a group where they have shown that the ovarian suppression effect of the drug goserelin during chemotherapy for breast cancer, it showed that this drug protects against the ovarian failure, decrease the risk of early menopause, and improves the prospect of fertility. And here they have recommended that GnRH administration should begin at least 10 days prior to chemotherapy because of the initial flare-up effect, and should continue till 2 weeks after the end of the chemotherapy. And in case of estrogen-sensitive tumors, tamoxifen therapy should be initiated after the GnRH analog treatment. So here there is a newer debate where ovarian tissue cryopreservation. The ASRM has recently mentioned that the ASRM has actually removed the experimental label from the ovarian tissue cryopreservation because it states that the ovarian tissue banking is an acceptable fertility preservation technique and it's no longer considered an experimental. The removal of this experimental label is based on overall evidence of safety of procuring ovarian tissue, cryopreserving the tissue, and transplanting thawed tissue orthotopically. And with ovarian tissue cryopreservation, almost as of 2017, almost 130 live births have been reported, and the female were of average age of 30 years at the time of cryopreservation, and this procedure was successful in producing live birth in almost 20 to 30% of cases. Hormone production was restored for up to say 12 years with the average of almost 2 to 5 years. And in this report, 18 patients were under the age of 21, that is 9 to 20 years, when they cryopreserved their tissue, and autotransplantation of the thawed tissues in each of these patients resulted in 10 live births, almost in 9 mothers. So OTC should be carried out in centers which has a clinical expertise. The success rate of this procedure depends upon the careful selection of patients, surgical expertise, and laboratory facilities. The advantage of ovarian tissue cryopreservation is no need to delay the cancer treatment. It avoids the risk of stimulation, no need of partner or donor sperm, preserve larger pool of follicles, and allow resumption of ovarian follicles. And the ovarian function resumes between 60 to 240 days post-transplant, and it lasts up to 7 years, and it is the only treatment option available for prepubertal girls. But the limitation is the possibility of reseeding of cancer cells. So in ovarian tissue cryopreservation, in case of prepubertal girls, we need only less than half the ovary, almost 20 to 30%. So we take the cortical tissues and we make it into tiny pieces, almost 2 to 3 millimeters, and then we load it in a cryo vial, and first they are subjected to vitrification solution and then they are vitrified, followed by, in case after thawing, either they can be transplanted, autotransplantation, or IVM can be done. Autotransplantation, so the thawed strips, the cortical strips, are transplanted back to the same patient, either in the pelvis or in the abdomen. Either it can be orthotrophic or heterotrophic. Orthotrophic is more successful and resulted in pregnancies, whereas heterotrophic, a group of Melbourne has recently quoted that they have a first ongoing pregnancy with a heterotrophic transplantation, where the tissue has been put in the a patient's abdominal wall, 2 oocytes were removed with mild stimulation, and embryos obtained were transferred into the uterus, resulting in a singleton pregnancy. So IVM we usually routinely use, we do it for all PCOD patients where we get majority of the GV oocytes. Usually we subject them to culture media which contains gonadotrophins like FSH, LH, nutrients, proteins and growth factors, and almost after 24 to 36 hours there is a resumption of meiosis from prophase 1 to the metaphase 2, which we can see it by the extrusion of the first polar body in the perivitelline space, and the implantation rate. So this is the implantation rate of IVM. In case of the ovarian tissue cryopreservation, that is, we freeze the ovarian tissues are frozen, and then the immatured oocytes are collected, and then the implantation rate of IVM is almost 10 to 15%. The future direction of fertility preservation strategies are artificial ovary, where this mimics a natural ovary. Either it can be it has both a physical aspect as well as the biological properties for the follicle survival and development. So here the ovarian primordial follicles are loaded in a matrix gel or extracellular matrix for a support to develop into a functional ovarian tissue, and these all were successful in a mice model, and this can be one of the future option for pubertal girls, young women with hematological malignancies for whom ovarian tissue cryopreservation is not recommended, or in those who cannot avoid treatment delay. So another future direction is transplantation of the intact ovary. The whole intact ovary is transplanted by vascular anastomosis. The first successful whole ovary cryopreservation was reported in the animal model, whereas in human it's technically challenging because of the ovary is large and more fibrotic tissue, and also the endothelial cells are sensitive to cryo injury, and if there is a endothelial cell damage, it can lead to organ failure after transplantation. Next would be mesenchymal stem cells, which are derived from the human endometrium, isolated from the menstrual blood. When this mesenchymal stem cells are supplemented with differential media containing 20% follicular fluid, they differentiated into germ cells, which are oocyte-like cells, and these oocyte-like cells expressed germ cell markers, as well as they tend to produce FSH and LH. They have FSH and LH receptors and produce estrogen and progesterone regulated by gonadotrophin, suggesting granulosa-like and theca-like cells. So fertility restoration. So before cancer therapy, the options are stimulate egg retrieval followed by embryo freezing, oocyte freezing, or ovarian tissue cryopreservation, whole ovary freezing. But after cancer therapy, if it's embryo freezing, direct embryo transfer. Oocyte freezing, we can do IVF followed by embryo transfer. If it's going to preservation, either transplantation or in vitro maturation. Transplantation, autotrophic, heterotrophic, again stimulate them followed by IVF and ICSI. Whereas IVM, it's IVF and embryo transfer. If it's a whole ovary freezing, transplantation by vascular anastomosis, natural conception. So fertility preservation strategies in male, where here the established procedures are gonadal shielding, gonadal transposition. Post-pubertal, we have semen cryopreservation, and investigational procedure we have testicular tissue cryopreservation or spermatogonial stem cell cryopreservation, and in post-pubertal is GnRH analog. So moving on to gonadal shielding, the physical gonadal shielding, as we have earlier discussed, it is to minimize the scatter radiation to the testes in both adult and children. In chemical gonadal shielding, it's a GnRH analog, but antioxidant, carnitin, anti-apoptotic agents and cryoprotective agents, but these all have a protective effect against chemo and radio in animal models, but not effective in humans. Semen cryopreservation. So this is one of the standard, effective and efficient method recommended before initiation of cancer therapy. Option for postpubertal and adult males, and all the patients should be screened and tested before sperm cryopreservation. The sample collection can be either by masturbation, penile vibratory stimulation, electroejaculation, and either 1 to 3 samples can be collected. So if there is a difficulty in sample procreation, or if it's a azoospermia, Then there are other options like epididymal aspiration or testicular biopsy. So in case of testicular biopsy, the patients are subjected to general anesthesia, and again the tissues are collected. Almost the size of the testicular tissues will be 80 to 250 cubic millimeter, and the tissues are minced and the teased apart, and the media which contains the final broth, so that will be frozen, whereas in micro-TZ has a higher sperm survival rate than the standard open biopsy, which is almost 63% versus the 45%. So this is the testicular tissue cryopreservation. So all the biopsy sample we collected in the culture media, and they are all teased and then frozen. So I'll just skip this guide. So the success rate with the thawed sperm, so fresh semen IUI is more successful than the frozen thawed semen IUI, and there is no differentiation in fertilization and the pregnancy rate between the fresh and the frozen thawed sperm in IVF and ICSI, and there is no difference between fresh and the frozen thawed testicular sample. There was one study which has showed that OncoTZ, 4 out of 6 men had sperm in testicular tissue and 2 were able to father a child following IVF. So this is the investigational procedure in case of prepubertal boys. Testicular tissue cryopreservation, a clinical option for prepubertal male, and even neonatal testicular tissue possesses spermatogonial stem cells. So the immature testicular tissues can be stored in either way, either as a cell suspension or as a tissue format. The cell suspension can be used later in germ cell transplantation or in vitro maturation, and if we have frozen as a tissue form, then it can be used as a testicular grafting or organ culture. So we usually subject them in cryoprotectant media, and it's usually stored in the vial and stored in the liquid nitrogen at minus 196 degrees. So all the patients' samples are labeled, return or computerized inventory system, and usually sperm sample can be frozen for decades. And there was one case where the sperm frozen for 28 years had resulted in a live birth. And there is no regulation for the length of storage, but the statutory maximum time period for storing sperm for medical reason is 55 years, and there should be an every year renewal in terms of payment as a maintenance cost, which is valid only for 1 year. Legal and ethical issues, we would be discussing this in the panel discussion. So the other experimental fertility preservation methods are spermatogonial stem cell transplantation, testicular tissue transplantation, ex vivo tissue maturation, in vitro spermatogenesis, microfluidic and pluripotent stem cell derived germ cell therapy. All these methods have produced sperm via spermatogenesis that are competent to fertilize oocytes and give rise to a viable offsprings. But these are all done in the animal model. But the greatest challenge is lack of experimental tool for testing the spermatogenetic and the fertile potential in human cells. So restoration in male, so recommended waiting period is almost 9 to 12 months post cancer treatment. However, the resumption of sperm production is not guaranteed. In case of sperm freezing, it can be thawed and utilized for IUI, IVF and ICSI. In case of testicular biopsy, it can be the testicular tissue can be crafted, or in vitro maturation can be done, followed by IVF and ICSI. And in case of cell suspension, these can be injected into the testis, like spermatogonial stem cell transplantation and natural conception. If not, in vitro maturation followed by IVF and ICSI. So to summarize, cancer may have a negative effect on male and female reproduction health through multiple pathophysiological mechanisms. Radiation and chemotherapy exhibit dose-dependent gonadotoxicity. Fertility preservation should be discussed with all cancer patients of a childhood stage or reproductive age group. Rising pregnancy rate of sperm cryopreservation, oocyte cryopreservation, live birth after transplantation of human ovarian tissue have shown promising future in the field of fertility preservation. Adjuvant procedure should be employed whenever and wherever appropriate. Innovative and possibly revolutionary technologies for fertility preservations are currently in development. Once these are established, many may change our current approaches to fertility preservation in cancer patients forever. Thank you.